I'm interviewing Professor Antonino Spinelli. Professor Spinelli is a very close friend who is the division chair of colorectal surgery at Humanitas University, Ground Zero in Milan, Italy, as well as a leader in the European Society of Coloproctology. And we'd like Dr. Spinelli to talk to us a little bit about his experience in Italy. Antonino, welcome. Thank you for working with the American College of Surgeons. Can you tell us a couple of things? Firstly, how quickly did the situation evolve in Milan? Matter of hours, days, weeks? How quickly did it evolve?
So thank you, Stephen, first of all, for the opportunity. Actually, in Italy, it has begun extremely sudden because we were not prepared to such a rush start of this emergency. We, in the very first weeks, we started to when we got the real sense that it was that the wave was coming, we started to prepare ourselves. But even if we understood that it was a serious thing, we did not succeed in getting the sense of how much it would have impacted and for how long in our lives.
So based upon that experience, talk to us a little bit about some of the actual clinical scenarios, like what happened to patients with cancers, what happened to patients with diverticulitis and appendicitis. How did you manage to triage or treat those patients?
So first of all, if you look at our hospital organization, if you have looked at that 1 month ago and now, it's completely a different place, even the organization of the hospital. Starting from that, which was dealt with by organizing a crisis unit that meets every day in order to change the hospital organization according to the changes in the development of the crisis. Then we also, if we look only at our colorectal specialty, then definitely the path and the care that we are able to give to our patients has dramatically changed, and not for the better, because we were used to give a lot of service to our patients, both cancer and non-cancer patients, as well as IBD patients. Now, even being one of the only 4 hospitals that are considered as hub for oncologic surgery within the region of Lombardy, which is 10 million people and is the most heavily affected region in Italy and probably in Europe, we only get to operate 6-8 cases per week of cancer, while we were on the average of 17-18. And now we do not only operate on our cases, but we also receive cases from other hospitals. That means that we had to prioritize, as you mentioned. Prioritizing even cancer patients is a particularly difficult task, and it has to be an objective. We have to try to do this in a more objective way we can, and therefore we established together with the HPB colleagues, with the pancreas colleagues, with the upper GI colleagues, and so on. We try to have an homogeneous way to measuring urgency and underferability of every operation. Something else is obviously for urgent or emergent cases. They are still possible to be operated on, but we tend to be as conservative and as in setting the indication for an emergency operation in these days, as we probably have not been in a more liberal way in the past.
What about some of the non-oncologic problems? If somebody presents to your hospital with appendicitis or diverticulitis, firstly, what are the precautions, if any, to test for COVID-19? And are you trying to temporize more patients without surgery?
Well, regarding the screening, now we believe that it is absolutely essential. And at the beginning, we tried to make a a screening based also on anamnestic criteria and also on the history. Now, with this prevalence, this high prevalence that we have in nowadays, it's really less helpful to know whether they have had a contact with a COVID positive patients or something like that, because nowadays we think that everyone is potentially a suspect COVID positive patient, given the very high number of asymptomatic individuals that have contracted the virus. So we now do we let every patient undergo a CT scan of the thorax, of the chest, before any surgery, any elective and emergency surgery. And if it's not a real emergency, that means that we have 4 or 6 hours, we also do a swab in order to see whether with a real-time PCR there is virus replication active in the person. Knowing this before surgery would allow also the operator and the team in the OR to be adequately protected.
So that gets to my next question. So let's say the CT is negative and you do not do a swab. As compared to a patient where the CT is highly suggestive or the swab is positive. So you have a patient who's presumed negative versus a patient, if there is such a thing left in Milan, or the patient who's known positive. What's the difference in the personal protective equipment in those two scenarios?
For sure, in the best possible world, we should treat every patient as a COVID positive until proven otherwise. If, as it is the scenario in many, many surgical units all over the world and also in Italy, then we do not have enough PPE to protect in this way not only all the surgeons, but also the anesthesiologists, the OR staff with full PPE. So under these shortage conditions, we only use those equipments in presence of known positivity or known or clear suspect. All the rest of the cases are dealt with conventional equipment. Conventional equipment obviously includes also protection, eye protection and eyewear protection and normal surgical gown and double glowing and conventional things. But we are not able, unfortunately, to give N95 plus visors plus special double gown for conventional, for cases that are not clearly COVID positive.
What about the environment in which the cases are done? Are the operating rooms negative pressure?
Yes, we have right after the start of the outbreak in Italy, we were able to convert an OR into a negative pressure OR. But in this, we would operate all the cases that are known COVID positive. As I mentioned, elective oncologic surgery in which there is CT chest negative and no suspicion or even negative swab, because that's what we are implementing now for oncologic patients. We are starting to do routine, even the swab, but that would be a case in which that we would operate in conventional positive pressure OR.
Okay, and is the one operating room that's been converted sufficient, or do you find yourself sometimes doing COVID positive cases in a positive pressure OR because you only have one negative OR?
Up to now, we have not operated that big amount of COVID positive patients that we had not found the place to do that in the only negative OR, negative pressure OR that we have. But we used to have 36 theaters going on the same time. Now, with the shortage, with the use of the OR blocks for as additional ICU beds, we only have one block of 6 ORs, not always all of them going at the same time. So it's an incredibly shrink surgical practice.
So that brings up my next question, which is who is staffing all of these additional intensive care unit beds. What measures have been taken at Humanitas University to retrain non-intensivists to help in the intensive care unit, other physicians to help in the emergency room with screening, and in general, retraining? At what point did you retrain, and who and how retrained?
So that was one of the first and the most important advices also that I can give. It was one of the first measures that we took in our crisis unit to retrain specifically in specific tasks in the simulation center from week one of the emergency. We now retrained more at different levels, but we trained more than 500 healthcare professionals specifically for COVID emergency. Some of them were only retrained in terms or trained in terms of correct protection, dressing and undressing. Other were retrained in terms of use of ventilation device. Other were retrained in terms of emergency triage. But we have been doing this from the very beginning. And this is a very important advice that I think should be given to our colleagues in the US as well. Regarding the number of physicians taking care of the respiratory patients, we have to say that out of about 260 patients with COVID positive we have at the moment in the hospital, 220 are in the normal ward, and in the normal ward we contribute also as surgeons, and each normal ward of 40 beds has about 8 patients on CPAP, on CPAP machines. So each of them had to relearn or to learn how to deal with that. The rest of the staff, the surgical staff who are not needed in the OR to go on with oncologic cases, they will be either split and stay home in order to prevent and to preserve them, to allow continuity in our care, or they would be helping other colleagues in the emergency room, basically.
Okay, so the last point I want to raise, and you just touched upon it, is going home and having shifts. So you divide the workforce into shifts. Can you just tell us a little bit what life has been like for you personally in the last month with this pandemic epicenter starting outside of China, starting in Milan?
So first message is everything changed at the moment. We really hope that this is not going to be an irreversible change for our lives, and we want our lives back. But at the moment, on a more so regarding the shift thing, I want to say that shifts have to be reconsidered completely, because we have seen that with the complete PPE, it's very often too heavy to stand for 8 hours, and we had to reduce the shifts to 6 hours because of the lack, let's say, of comfort with the full equipment. Meaning, you have to remember, you cannot drink, you cannot go to the restroom, you can not, and you sweat a lot also. So these are things that have to be taken into account when organizing the shifts. Second, for me personally, what my priority was definitely, as most of other colleagues having a family, was to preserve as much as possible the families. So we tried to find ways to live outside of the family since when it started. This is obviously not easy, and not for everyone, because not everyone has the facility to do so. But I think that that has a value in terms of preservation of being a high-risk person, a highly exposed person. Social life is basically not there, because we only see the hospital and the bed. So that's it. But we are very, my message is we have to be extremely positive, very flexible, very open, and we definitely have to be resilient, because, as said, we will have our lives back, and we have to go through this and to help others doing the same.
Well, thanks so much, Antonino, for your time. I'm sorry to take you away from the patients, but your message is very profound and full of sage advice for those of us in the United States who've not yet seen the surge hit. Certainly, you and our other colleagues in heavily hit areas are in our hearts and minds every day, and our prayers every day. And we wish you sustained health and sustained safety. And your optimistic ending note is very appropriate. Looking forward to getting back to normal family life and normal socialization. We also hope and pray that that time comes very soon. So thank you again, Professor Antonino Spinelli, and we wish you sustained health.
Thank you very much, and wish you all the best.